uh, the substance abuse also less severe. As a quadrant or resource capital, she will be in quadrant 2. There was low problem and low resource capital as the provided information. As a counselor, I was counseling and psychoeducation about the panic disorder, the negative consequences of drinking, and I will motivate her by motivational interviewing. And I will also ask about the suicidal ideation. And I will also consider about medication if she wants to stop drinking. The problems that I would encounter are she has financial problems and her educational status is low and her drinking habits will be the problem. Thanks.
Thanks, Dr. Ang. Dr. Ang, from what you already have, is there any other disorder that you would like to rule out, that you'd like to look into?
You mean medical disorder?
What disorder, please?
Medical or mental?
Mental. Any other mental disorder that you'd like to look into?
According to the information, there was no mental disorder history in her relatives and herself. As a medical disorder, I would like to check about thyroid function test for thyroid disorder.
Why? Any reason why thyroid?
Yes. The anxiety are highly associated with thyroid disorder.
Yep. And also, as we talked last time, remember, whenever you have anxiety, always rule out depression. Yeah. So depressive disorder is also the other thing that.
Yes.
Yeah. Good. Well done. Well done. Okay. Well done. Okay. Thanks a lot, Tom. Thank you. Can we go on to group 3, please?
Yes. I'm Dr. Agahay.
Okay.
First of all, I would like to present my case scenario.
Yeah.
Paul was a 25 years old Rwanda immigrant who had witnessed Rwanda genocide at the age of 8. He is now dependent on benzodiazepines.
Okay.
He had been married now for 3 years, and now his marital stress forced him to seek treatment. And because his drug habit is having negative effect on his marriage. And he initially presented with increased level of anxiety, fidgetiness, ineffectiveness, guilt, shame, hopelessness, social withdrawal, being threatened, and he also has somatic symptoms, and he has a he has a lack of trust in people in authority, a lack of trust in people in charge. Regarding his past history, he witnessed the death of his neighbors and arrest of his parents at the age of 8. Uh, and there is also strong avoidance of discussion about the events of his life before the age of 8. And his wife said he has been increasingly reliant on drugs, um, uh, which seems to have been precipitated by his depression, insomnia, and vivid memories of the tragic past. He even refused to talk about his tragic events with his wife. He also has difficulty in concentration and angry outbursts, guilt, and paranoia. And his job is also affected because of his lack of concentration and his tension with his co-workers. And he can be said to be socially withdrawn. His symptoms uh, are, are precipitated when a noisy adolescent seemed to be walking towards him, and his reaction is to run and hide behind his house. And he also has flashback with more frequency. And this is his scenario. And my diagnosis is post-traumatic post-traumatic stress disorder with co-occurring substance use disorder, benzodiazepines. My points for diagnosis are uh, the patient is older than 6 years, and and his symptoms persist for more than 1 month. Uh, like he he witnessed in person of the uh, tragic events, and the loss of his family members and neighbors. Hello, hello. Sorry, sir. The electricity is also. I'm using my internet with my phone. Can you hear me? Hello.
Yeah, yes, we can.
Yeah, we can
Okay,
hear
okay.
you. Yeah.
Yeah, my points for diagnosis are one more. He is more than 6 years old, and the symptom persists for more than 1 month. And he number two, he witnessed in person of the tragic events. And three, loss of uh, close family members and neighbors. Uh, four, and flashback of his tragic events and vivid memories of his tragic events. Uh, five, intense psychological distress at exposure to external cues resembling the tragic event. In here, his symptoms were precipitated when he encountered a noisy adolescent walking through towards him. And this is the tragic events, external cues, or resembling the traumatic event here in this case. Six, uh, persistent avoidance of external reminders. He doesn't want to talk about his tragic past even with his wife. He doesn't want to talk about the events before the age of 8. Uh, Seven, persistent negative emotion. And here the patient has fear, guilt, and shame. And eight, markedly diminished participation in activities. And here the patient is socially withdrawn. He doesn't want to talk to anyone. And number nine, angry outbursts. The patient has it. 10, self-destructive behavior. Here the patient is dependent on benzodiazepines, which is self-destructive behavior. And he also has concentration problems, sleep problems, and social and occupational impairments. These are my points for diagnosis. The management plan, as a management plan, uh, I would like to employ the integrated approach because the patient has a post-traumatic stress disorder and co-occurring substance use disorder, benzodiazepines. So I would like to employ a integrated approach uh, in which various specialists or various professionals can can cooperate or collaborate in the care of patient. That would entail pharmacotherapy, cognitive behavioral therapy for both PTSD and SUD, and also group therapy, mutual help group, and spouse counseling might help in the help of the patient. So, as for the patient, I can't determine the patient recovery capital because exactly the patient recovery capital. He seems to have a wife and own family, but not the other recovery capital are not given in the scenario. So I will put the patient in a quadrant 3 because he has got the PTSD and also the sustained disabilities that not as severe as put in quadrant 4. Regarding his problems, the patient has PTSD and co-concurring substance use disorder, and therefore the problem is poor outcome. The latest evidence suggests poor outcomes. I also think that the patient has multiple psychiatric problems on top of PTSD and SUD, and they are depression, anxiety, and antisocial personality. That's the end of my presentation, sir.
Thanks a lot. Thanks a lot, Dr. Akka. I think there was a very complete presentation. And just one question. I mean, the substance that he uses, why do you think he uses the substance? How is it helping him?
I think he's got anxiety, insomnia, and also the vivid memories, the dreams. It calmed him. When he became agitated, and the benzodiazepine calmed him. It helped him sleep better. So I think drug of drug of choice for abuse is I think benzodiazepine is good.
Yep, correct. So we all must understand that every substance that's chosen by your client has a meaning to them. So they don't use it because they just like to use it or want to use it. It helps them in something, and that's something that we've got to learn. We've got to try to understand how does it help so that we can help them get over those substance. Sometimes people with trauma also use downers like alcohol and benzodiazepines in helping them deal with their problem. Okay, how about let's move on to the fourth presentation, please.
I'm sorry I don't have the slide to share, but can I just talk? I couldn't find the link, but after for my lunch.
Problems, carry on.
I've just briefly told the group about the case. I got Lena, 22-year-old woman. She used to have a treatment but then she dropped out after the first few weeks because she couldn't concentrate on the group sessions. And from her history, she has difficult staying focused. And because the reason that she quit the program because she couldn't concentrate 3 hours intensive group sessions. And from her history, she had difficulty in schools, and she has a history of doing drug and alcohol use. And then she quit several jobs, because but she said she wasn't fired, but she got bored. So from her history, I would think her diagnosis would be the ADHD with SUDs, because she has a difficulty, she's restlessness, and then she couldn't concentrate for the group sessions. She couldn't focus, and she when about her history, she forgot things notebooks and then all the important resources. And then when she works in the restaurant, she sometimes forgot what people ordered, and she has pretty much distractions. So diagnosis of, in my opinion, would be like the ADHD, and for the management, I would think like we had to help her, because in the history, I mean, from the case didn't say like whether she meets the doctor for her treatment or not. But like I'm not sure if she quit the medications or not. So we, as a counselor, I would just refer to like, you know, just to make sure with her whether she still be on the medications, and because it help her to concentrate more, and then more like attention to things, and then probably help her to develop some like skills that about like task management and all those things. Because and every time that she came for the counseling, like I have to realize that probably she will like very difficult, I mean very easy to distract, and then like maybe like she like very struggle, like if I want her like you know, like have some skills, she probably like cannot focus, and then cannot like comply with the, so I would like to develop some like all those task management, like do things in a like help, maybe some organization tools that help her to concentrate more, and also like whenever that she is in the session, I will try to distract all the stimuli, because she will easily to distract, and well, like for now that's all. Thank you.
Thanks a lot. I think that was a good presentation, Dr. Supapa. Just want to ask you, why do you think that she likes to play video games?
It was fun, and I think because this one, I think like although like they said the people with ADHD sometimes has difficulty to concentrate, but I think it's just like maybe a reward session. I mean like maybe something fun, like a reward circuit, whatever, like you know, like in the brain that she had fun, and then so that's why it's still like attract her to play the games on her cell phone.
But you know, amazingly, as much as people say that they have lack of focus, kids with ADHD or people with ADHD, when they do things that they like, they are able to focus. And computer games, you know, whether you believe it or not, actually helps with focus and cognitive function. The proof is we use it in treatment for mental disorders with cognitive defect, especially in patients with schizophrenia, with a lack of memory, focus. We use a lot of computer-based games or treatment. It's treatment, you know. And also anywhere overseas, you know, pilots, people who fly planes, always do their simulation practice or training through computer. So it actually helps with attention and concentration. So a lot of them like games, but the problem is that is where they get too addicted to games and they can't leave it. You know, so that's the other issue, right? Okay. Thanks a lot. Thanks a lot. Okay.
Thank you.
All right. So I'd like to thank all four groups. Thank you so much. I think that was very good work, very wonderful presentations, and good interpretations. Okay. So let me encourage everyone to look into mental health problems among your SUD clients, because it is so common. It is so common. Sometimes it's almost close to 30 to 50% of the time. So always look into it. All right. Okay. So we shall move on. Okay. We shall move on with what we're doing, and then maybe if we have time, we'll open up for some questions in a while. Okay. So we'll just move on, and I'd like to start off with right, something that's called substance-induced mental disorder. We were talking all the while about COD, co-occurring, but now we are going to take a few minutes off track and talk about substance-induced mental disorder. Now, COD is something, substance-induced is just the different thing, you know. So, have you heard about it? If you have, what are your understanding about what do you think are substance-induced mental disorder? Maybe put down some of your thoughts. What do you think are substance-induced mental disorder? And what are its problems? What problems could it bring, in terms of uh, physical, psychological, social? What kind of problem do you think it could bring? Okay, could bring psychosis. So some people have written about methamphetamine-induced psychosis attack the brain. Okay, in what way does it attack? Also, so it can also bring depression, which is correct. Okay, SUD effect, mental, right? Anxiety. Okay. Anything else? Okay, the use for substance for a long time, it affects the brain, right? Any last thing before I this thing? Yes. So we're talking about brain damage. Okay. So we're talking about brain damage. Uh, you're all correct. Okay. What substance-induced psychotic disorder means, or substance-induced psychiatric disorder, mental disorder, is actually where substances can imitate mental disorder. And the effect of the substance, or the mental disorder is actually a direct result of the substance. That means not like what we talked just now, COD is independent of each other. They're just occurring at the same time. But here, substance-induced mental disorder is basically the direct result, okay, of the substance use. So it occurs at a specific time, okay? It is due to the substance. It is due to the substance. We'll talk about some example, either when you use the substance, when you're abusing the substance, maybe when you're intoxicating, or during withdrawal, So it is a direct, here, induced disorders is a direct result of the substance. So what can they cause? They can cause mild anxiety, they can cause depression, They can also cause more severe things like mania and psychotic reaction. Can I just stop here and ask anyone, can you name me, other than that you already mentioned just now, you mentioned about methamphetamine-induced psychosis. Can you name me other substance-induced mental disorders? Anyone? Any other mental-induced psychotic disorders that you know? Or, sorry, substance-induced mental disorders? Alcohol can cause? Alcohol can cause what? You're right. But what can it cause?
Cannabis.
Cannabis can
Cannabis.
cause what? Yeah, cannabis causing psychosis. Okay. How about alcohol? Alcohol can cause what? Anyone? What can alcohol cause?
Psychosis.
Alcohol can cause psychosis. Alcohol can cause depression. So multiple things that many substances can do. Okay. There is something called a teeter-totter principle. So what is a teeter-totter? A teeter-totter is basically a seesaw. It's just like this, a seesaw, all right? So what the teeter-totter principle says is, what goes up must come down. So if a substance causes or stimulates the human mind when you use it, when you withdraw from the substance, it causes the opposite. Okay? Just the opposite. That is what it means. So, in that way, when you understand that, it is useful for you to understand what kind of presentation your clients can present with. For example, if I have anxiety and if I use alcohol, what happens to my anxiety? Anyone?
It can calm
What
worse.
happens to my if I have anxiety and I use alcohol, what happens to my anxiety? Does it become worse
It
or do I
becomes
calm
worse.
down? The anxiety doesn't become worse when I use alcohol,
No,
because
it's
alcohol is,
soothes your anxiety. It calms you down. Alcohol calms you down.
yeah, alcohol is a downer. So alcohol and benzodiazepines are downers. So what they do is it brings down your anxiety and it calms. When I stop the alcohol, suddenly what happens?
Anxiety increasing.
Exactly, the anxiety increases. This is what you call as teeter totter. When I use, if the substance is a stimulant, when I use it, I get stimulated. When I stop, I get depressed. That is what the teeter totter principle means, you know. Like, for example, here, acute withdrawal for depressants, you know, alcohol and benzodiazepine. The same thing for stimulants. For Met-M, when I use methamphetamine, what happens to me? What happens to me? How do I become?
You'll become alert, active.
If
Your
I use a lot,
might got hypothermia.
yeah, and I also can get psychotic, isn't it? If I use too much,
Yeah.
yeah. So when I stop, what do you think can happen in the first phase? What do you think can happen when I stop amphetamines? When I use, it goes up. When I stop,
You can get low mood, depressed.
it will go move. Exactly. So I become very tired. I become very fatigued, and my mood can fall down. It's like depression like thing. So that is exactly what it means by teeter totter principle, you know. So you're expecting to see that just to understand what exactly happens. The only problem is now in most of our centers or most of our place, we see a lot of clients who are multi-drug abusers. So they don't just use one drug, they use multiple drugs. So there is a combination of some stimulants, some downers, some dissociative drugs. And so the picture is all mixed up. And that is one problem that we have nowadays. So it's very difficult to predict what they are using unless you're going to test toxicology through urine, you know. So it makes it all the more difficult. And you need continuing evaluation. If it's a drug induced disorder, okay, let's say if someone has come in and I feel it is a methamphetamine induced psychosis. If I stop the methamphetamine, what do you think will happen to the psychosis? Will it go on or will it stop if it's a drug induced disorder?
I think it will go on.
If it's a drug induced disorder, do you think it will stop or it will go on? What are your thoughts? Yeah, it should stop. It should stop if
It should
it's a
stop.
drug. Yes. If it does not stop and if it continues, then it is a co-occurring disorder. Okay? So you see there are some symptoms that don't improve quickly. Sometimes psychotic symptoms, a long time to go. So normally we give them a period of a month. Now, there's also some people who present with dementia-like symptom. Dementia is forgetfulness, memory, and this could be because of the damage that some of the substances has caused. More so alcohol, very common. Alcohol-induced dementia. All right, these are some of the symptoms. So the problem here is the substance can actually mask symptoms of mental disorder. So it might either delay your treatment or it may cause some behavioral crisis. Now, let me just explain myself again. Maybe I think the entire aim of the module is for you to differentiate between co-occurring disorder, okay, compared to substance-induced disorders. To differentiate one from the other. They are not the same, they are different. How are they different? Because in co-occurring disorder, you have a mental disorder, yes. You also have a substance use disorder, correct. But both of them are independent. They are not directly related to each other. They are occurring at the same time, but they are independent of each other. What I mean by independent is, like for example, a patient with schizophrenia smoking, taking nicotine. That is independent. The schizophrenia not directly causing the nicotine dependence, nor is the nicotine dependence causing the schizophrenia. They are independent. So when they are independent in COD, I got to treat both together. Because if I only treat schizophrenia, like we said just now, sequential treatment, only treat schizophrenia, the nicotine dependence is not going to stop. If I just treat the nicotine dependence, the schizophrenia is not going to stop. So if I want to stop both, I must treat both together at the same time. Now, that is different, COD. What we are talking now is drug-induced, okay? Drug-induced disorder. Now, drug-induced disorder, substance-induced disorder, you have a substance use disorder, yes, and you also have a mental health problem, yes, but they are related to each other. The substance is directly causing the mental problem. Example, I am fine, then I go and use methamphetamine, and I become psychosis. So the psychosis is due to my methamphetamine use. If I stop the methamphetamine, the psychosis should stop because it's related. It should stop. The same thing. If I am fine, but I go and smoke cannabis and then I get psychosis, it is the cannabis that is causing the psychosis, direct. So this is cannabis-induced psychotic disorder. If I stop the cannabis, the psychosis should stop. Then it is a substance-induced. Okay, so understand the difference between COD and substance use. Now, why is it so important? It's because the treatment, okay, in the treatment. When I treat a COD, because I understand that both are independent of each other, my treatment needs to be long-term. Long-term. But if I treat drug-induced psychosis or drug-induced mental disorder, my treatment is short-term because I only need to treat the substance use disorder. When I treat the substance use disorder, the mental health problem should go away. So even if, let's say, someone presents to me, okay, I'll give you an example. When I started off with in the field of substance use, one day I found one chap was brought into the psychiatry unit, and he was a very thin, small size chap, but he was brought by 5 policemen because he was very strong. And they also had to tie up his hand because he was very aggressive. So he came to the wards, he was very psychotic. So we gave him antipsychotic because he couldn't talk, he couldn't give any information. One day we gave him antipsychotic injection. Second day, he is calm and he can talk to us. And when he talked to us, he told us he was using cannabis. So he started using more cannabis. Then he started hearing voices, Then he became psychotic. So within 24 to 48 hours, the cannabis went away from his body and he was calm. No psychosis. So we stopped the antipsychotic. So what I'm trying to tell you from that example is when it's a drug-induced psychosis or mental disorder, treatment of the mental disorder don't have to be long-term. It can be short-term. So it changes the way you treat both. Okay, so that's the importance of actually knowing both. All right, so let's see what you think about this. Which of the following is correct about substance-induced mental disorder? A, are the results of substance use, substance-induced mental disorder is the result of substance use, abuse, intoxication, or withdrawal. The withdrawal always produces symptoms that are opposite of the effects of the substance. The toxic effect of substance can imitate mental disorders and makes it difficult to identify. Symptoms of substance-induced mental disorder are the direct result, or do you think that it's A, B, C, and D, all of the above? What do you think? Which is correct?
All of the above.
I'm waiting for people to vote. Okay, I'm going to lock this. All right. Yeah. Actually, the answer is all of the above. Okay, all of the above. So just like what we covered, substance-induced mental disorder can happen when you are using substance, abusing, intoxication, or withdrawal. Doesn't matter what, whether you're withdrawing or not. Induced disorders can occur at any stage. And normally when you withdraw, remember, it produces the symptoms which are just opposite of the effect. It's also called, what is the other word for this? What principle?
Teeter-totter. Yes.
Teeter-totter principle. Okay. The third one, toxic effect can imitate mental disorders. It's true. They can imitate, like when someone with schizophrenia uses methamphetamine can cause psychosis, and the psychosis can look very much like schizophrenic psychotic symptoms. All right. And of course, just what we told just now, the effect or the symptoms of substance-induced disorders are direct results of the substance use. Okay. So the answer is actually all of the above. Okay. Can I maybe stop here for 5 minutes just to ask for questions? Any doubts that you have on what we have covered right from the morning until substance-induced disorder? Any questions at all before we go to the last module? Any questions? Any doubts?
I have a questions because I was wondering about the substance-induced mental disorders and also like the COD. How the doctor differentiate when just the patient, but just saw the patients came, because
to make the first diagnosis? I mean, between these two.
Yeah, it's a good question. It's a very good question. So, what will help you with differentiating one from the other? One is you got to get a very good history, a very good history. So, you got to get your history of substance use. So, if you get a history where, let's say, before substance use, your patient was no psychiatric symptoms, but then he used the substance, and after that, only after that, he presented with psychiatric symptoms, then there is a high possibility that it is an induced disorder. So it is a question of the chicken, which one came first? You know, did the chicken come first or the egg? So it goes back to that, right?
Okay.
Yeah, but you know, sometimes it is so difficult to say because when you ask your client, your client might say, "Oh, I have both at the same time." You know, I have both at the same time. So whenever you have both at the same time and you cannot draw a line, then it is always good for you to stop one first. Stop the substance, you know, and
Okay.
watch. And that is what we do normally when people are admitted. It is so much easier. We stop the substance and then we wait and watch, you know, and we treat them symptomatically. So my understanding is if I'm waiting and watching, if I stop the substance, if it is an induced disorder, then the symptoms should stop. But if it doesn't stop, then I know I'm most probably dealing with a co-occurring disorder.
Okay, I see. Thank you.
How long does it usually take for a chronic the methamphetamine-induced psychosis caused by chronic prolonged meth abuse? How long does it take to go away if it is indeed a substance-induced psychosis?
Normally it is advised that we give people at least 4 weeks, a month. But it all depends on many factors. It depends on what you're using. Like, for example, things like opioids, methamphetamine are washed out faster compared to cannabis. Cannabis takes a longer time to wash out. Number two, it also depends on the person himself and how fast you metabolize your drug. Some people are fast metabolizers, so it gets washed very fast. So it depends on multiple factors. But normally, when you look at books, they'll always say a month.
Thank you, Professor.
Any further doubts? Any further questions? Okay. All right. Thank you. Now, I'm going on to something which is totally different. Okay. It is actually common co-occurring. Just now, what we covered in the morning was co-occurring mental disorders. But now I'm covering co-occurring medical disorders. All right. So, in short, we are going to touch on HIV, hepatitis, and tuberculosis. All right. Because the priority that we have, okay, you find that HIV, hepatitis, and TB or tuberculosis are very closely linked to substance use. And UNODC has basically listed some challenges, especially security, development, social, and health cohesion, you know. So that's the priority. So these are our learning objectives here. We're talking about those three disorders and what its connection is with SUD, all right? So let me ask you this. I mean, what are your understanding around HIV? I'm sure, though you don't treat, but I think HIV is something that's very common in the region and in Asia, in the world, I would say. What do you understand around HIV? Sexually transmitted, very good. Okay, all right. Yeah. So, yes. So I see there's a lot of knowledge on this. So many people are experts. So you don't have to be a medical person. You don't even have to be related to the medical field to know about HIV because it's so common out there that people have got good knowledge. So makes my work easier. So we know the huge word here is immune system. All right. And that's exactly what HIV is actually. So these are some of the terminologies that you must know, you know, what it basically means. You can always read through those things, okay, and understand. So as you have said, through sexual uh, mode. So it cannot be through touch, cannot be through kiss, you know, it cannot be through sharing plates. So we have to get rid of all this, you know. The reason why we counselors should know about it is we have to educate our clients. I'm sure you will have clients who are HIV positive and who are on treatment, you know. So some of the reasons that people get HIV is sharing needles, you know, that's blood-borne, you know. A lot of people are scared about touching blood and this, but you must understand that it is not so easy, you know, to get HIV. Because one is the virus cannot last outside. When it's exposed to UV light, it gets killed. Okay, so it cannot. It can only transmit when there's a lot of bleeding or when it's through sex or from mother to child. Some of the symptoms that you can get, you know, of HIV during the first phase of infection is things like fever, headache, you know, your lymph nodes gets enlarged, you know, you feel very tired. That's because your immunity comes down, you know, your immunity comes down. So when your immunity comes down, it means that you are weak, your body is weak, and you can be infected by others. The danger is not you infecting others, it's others infecting you because your immunity comes down. And you find that later on, people lose heat, they have night sweats, you know, the tired gets worse. And when infection comes in, you find that there's a lot of swelling, especially during the armpit, the groin, the neck, you know, and people have diarrhea. So sores in the mouth, you know, around the anal region, the genital. Because of infection, people have got lung infection like pneumonia, you know. In your tongue, you have whitish fungal growth, you know. And in the later stage, because of fungal infection in the brain, people start having other brain disorders like memory loss, depression, okay, those things. Now, it is basically most of the time, most of the symptoms are caused by other illnesses. The HIV virus attacks your immunity and it brings it down, you know, and then you are prone for other illnesses, you know. So testing is very important, and we now try to tell all our clients, know your status. Know your status. The earlier you know your status, the better it is. Because we know we've got good treatment all over the world. And in most countries, your first line treatment is still free, you know. Treatment is good, it's effective, it does not kill or eliminate the virus, but it brings down your viral load to zero. It can bring down your viral load to zero, and you can live a productive life, you know. The treatment that we use is something called HART, okay, which stands for highly active antiviral therapy. It's a combination of a few medications, all right, and it's very strong. So yes, when it's strong, you always feel side effects are there, you know, but you can't stop it, you know, because it's effective. What it does is it stops the HIV virus from multiplying. So you find we check for viral load. Viral load has to come down, right? So when the viral load comes down, it's go away. It doesn't become AIDS. What is AIDS? AIDS is when your HIV virus becomes a lot, the load goes up, and it starts affecting your liver, your lungs, all your organs. Then it becomes something called as acquired immunodeficiency syndrome. That means it's affected all your body. That's somewhat towards a later stage, okay? But with proper detection and proper treatment, healthy lifestyle, you can lead a productive, healthy life. When do you start? Okay, I've got to get your advice on this, but normally treatment is recommended, okay, as soon as a diagnosis of HIV is done, regardless of CD4 cell counts. But this first statement very much depends on countries and what your health policy is. Some countries wait for the CD4 to come down, you know, down to about 300 and below, then they start. So they don't start immediately. They don't start immediately, you know. Some other conditions where they start immediately is pregnancy. A lot of people feel that when you're pregnant and you have HIV positive, you can't start on treatment. No, it is safe to start on treatment even if you have a child. It is the best. It is recommended because if the mother is HIV positive and if you start on HART treatment, the baby will be born, got a good chance of being born HIV negative. You know? Very good chance. So that is one that we immediately start. Of course, when your count comes down, when you have AIDS, you have to start. Or when you have infections related to HIV, like pneumonia, you know, you have to start. So the take is, as soon as it's detected, the faster you detect, the faster you start, the better the chance of zero viral load. You know? Sad to say, some people don't respond to the HART treatment, you know, and they build something called as drug resistance. So when there is drug resistance, they have to use second line, third line drugs, and sometimes can be expensive and more side effects because stronger. Okay, so that's how we basically go with it. You know, we test for drug resistance, we monitor the success, and we change medications if possible. All right, but a huge proportion of people respond well to the first line medications. But sad to say, you know, all around the world, not everyone is being able to assess. I think in Asia, we've got most probably one of the better accessibility rates. You know, a lot of people in other parts of the world do not receive treatment, and it's still a problem there. I think at least in Thailand, Myanmar, and Malaysia, and other Asian countries, we're actually doing a better job in that sense. Now, how wide is it? It's still a big number, HIV, although because of the implementation of medication, it's better controlled. All right, it's better controlled. Now, let's talk about the connection of HIV and substances. Well, you know that one of the reasons why why substance users get HIV is because these are people who inject drugs. Okay, and you find that there's a huge amount of people who basically inject drugs. Very high among the opioid drug users or drug abusers. Now there is also gender mental disorders that we saw. Gender differences between men and women on how they get infected with HIV, and also consequences, social and economic, very different because of the biological difference, more so because of sexual behavior also, and their cultural roles. And as much as we want to say we are equal, around Asia, there is still very much a big gap between the accessibility of resources and decision making among men and women. Sad to say, you find that a lot of services that we have in many places are still very male orientated and less to the female. So you find very few females actually going out for treatment, because most of the treatment centers are dominated by men. That's not good. That's not good, because what we see nowadays is we are seeing a lot of younger aged women showing high prevalence rate compared to men. So they have to reach out. But to reach out, you must have specific services for females, because it's very much different. You're looking at different demands and different modes of treatment. All right. Now, there has been studies which show that this was very early studies. There was a difference between men and women in terms of contracting HIV. Okay, but I think on the whole, I don't think there is much of a significant difference at all. I think both males and females have equal opportunities and chances to get or to contract HIV. Right? So it's not a gender issue. Now, pregnancy, as we say, pregnancy, HIV in pregnancy and childbearing issues, the first advice by a doctor is get on heart treatment as soon as possible. And there is very good data to show its safety, and also very good data to show that the child will be born HIV negative. But of course, you've got to be careful when you're breastfeeding the child later on, because as we said, HIV can be transmitted through breast milk. Okay. So there are many other reasons. Mothers who decide to discontinue breastfeeding, okay, who have to change to infant formula to reduce the risk, okay, and also to other issues pertaining to stigma and discrimination. So there are some gender norms, okay, gender norms which increase vulnerability to HIV, especially in young women, okay, especially in young women and young people actually. Many young women knew little about their bodies, contraception, and sexual transmitted infection. And it is where we basically tend to teach people as young as college or high school students about safe sex, because you can't stop people from practicing sex, but at least if they have good information on sex, on safe sex, condoms, we can bring them up through safe behaviors. The sad part is you can't stop people from having sex. But the problem is if you don't educate them, then they grow up with this wrong feeling that if I use condoms or if I use contraception, then people will think I am sexually active, I'm sexually promiscuous, and that sort of chases them away from using those, putting them into danger, actually. Violence is also another source of HIV infection through rape, and other threats of violence. So those are very common ones that we basically see. So programs, especially UNAIDS, UNAIDS have found that there is a huge difference, between genders, especially when you talk about HIV, where they found that in men, being infected, and cared for the infection was hardly questioned. But when women get infected, women were always blamed for unnecessary things. So I think this kind of things should actually be taken away, and programs should be fair. We should have proper specific programs for females. So as SUD counselors, your job when you come across clients with either HIV or AIDS, education, very important. Okay, talk about sexual parental transmission, of HIV, because even though your client may be positive, but he's got a responsibility not to infect others. And also talk about the misconceptions about HIV, because there's a lot of misunderstanding. The most important thing that you as SUD counselors should do is encouraging adherence. It is so important to be adherent to the medication, because without adherence, it doesn't work. If you lapse from medication and when you discontinue, your first line medication may not work. All right. So this module is basically information for you to understand, because it is not uncommon that many of your clients may have either HIV, hepatitis, or tuberculosis. Okay. I'm moving on to tuberculosis because I think it's something that's very rampant in the Asian region. Tuberculosis is something very common. What do you actually understand by tuberculosis? What is your danger of tuberculosis? Is it very rampant in where you sit? Can it be treated? What do you think? That's good. HIV was a virus, isn't it? HIV was a virus. Tuberculosis is a bit different because it's a bacterium. Yeah. And I think we've got quite good detection for tuberculosis. But what has happened is tuberculosis has changed over the years, It no longer presents itself as how it used to. So yes, mycobacterium is that main thing. I'm going to lock it there. We've got sputum tests, we've got airborne, Sometimes the danger is it can stay dormant. Very good, So I think a lot of people are aware of it. It's very common. It used to only affect the lungs as we knew, but now it can affect every part of the body. Why so common? It's just like COVID. It's airborne. It's airborne. All you need is a social contact and for you to be immunocompromised and you get affected by tuberculosis. And the rates are actually quite high. We've got high rates in Africa, in Asia, and normally it's about people with immunocompromised states. And that's where substance-induced population comes in. We used to think, this was some of the typical symptoms: cough, maybe some blood in the cough, fever, night sweats, weight loss, another infection. But nowadays it's changed, you no longer find this classical thing. Sometimes people can be asymptomatic, and just maybe lose weight, just cough, nothing else, If you don't treat, it can be a killer. It can be a killer and it spreads very fast. And why not treat? Because we've got very good medication. So we've got this regime of isoniazid, rifampicin, ethambutol, pyrazinamide, and we've got newer ones nowadays, very classical. So whenever you want to know whether your client is on treatment with tuberculosis, you just ask him, what color is your urine? And normally people who are compliant with this regime, the urine will be red in color. Why red? Because of the rifampicin. Rifampicin discolors your urine. Other tests that we do a Manto test, that is a skin test to see, but the best would actually be sputum. Chest x-rays are also done, we also look at body fluid, but sputum is one of the more effective ones that we actually do. Now, there's a huge relationship of SUDs and TB, It's about almost 59%, 60%, because one is they are immunocompromised, and there is always a grouping of people together whenever people share and use substances in those days. Just like HIV, there is something called as drug-resistant TB, where you have an improper use of antibiotics, which has caused that. So this becomes a huge problem, huge problem, and you have to use other medications for drug-resistant tuberculosis. So first-line drugs may not work anymore, and you have to use stronger second-line drugs. And the sad part is, the stronger the medication, the more the side effects, So we are seeing it extensively, okay? Drug-resistant tuberculosis, but sad to say, we don't have much knowledge or treatment options anymore other than the second-line drugs. And sometimes even that doesn't work. So we always tell our client, be compliant to your first line. Don't stop. The problem with SUD is when you're immunocompromised, you tend to get infected. You tend to get infected, and your chances of being compliant, your SUD patients of being compliant is much less. So you find there's a high rate of default among clients who use SUD. And when they default, they relapse, and then they transmit it to all the other people in the community, and that's very high. So as counselors, your job here is basically educate your client about the disease, So important, just like HIV. You have to stress on medicine or medication adherence. So very important, because they run high rates of defaulting treatment. Okay, so that's tuberculosis. Okay, let's just finish up hepatitis before we open up for any questions. Okay, so what do you understand about hepatitis? Now, hepatitis has been there some time, but we are seeing different ranges of hepatitis. Last time we only knew about A, then we knew about B. Now we have C, and we have so on. By the time I think it'll go up to Z. So there's so many types of hepatitis. What do you understand by hepatitis? And is it a problem where you are? Do you see your clients having hepatitis? It's A, yes, it's food. But the others, are mainly infection, blood-borne, especially hepatitis C, All right. Okay. So I'll just lock this. Yep. Yeah. So I think people are actually quite well aware of this at this moment. It actually affects the liver. So it's a huge thing to the liver, and it can cause quite detrimental changes to the liver. So we've known A, B, C, D, and E. Now B and C are very common now because it can become chronic, affects the liver. A, it's oral. B is blood and sexual, and C is also blood. And you find that in C, there's a high rate of SUD clients having C because of needle use. So a lot of people don't realize they have hepatitis until they start having symptoms, because it affects the liver. You find that you get fatigue, feel very unwell, flu-like symptoms. People start losing appetite and weight. And when the liver is affected, you start having jaundice, where you feel your entire body turns yellow. Then you start having pain, vomiting, diarrhea, start feeling itchy, and your urine also becomes dark, like tea colored, and your bowels become very pale. So these are later symptoms of hepatitis. Now, the damage to the liver is it can change a healthy liver to something called cirrhosis. So cirrhosis is where the liver gets damaged and it cannot change back to healthy. Between this healthy and cirrhosis, there is also another stage where they become something called fatty liver. Now, fatty liver is still reversible. The problem is once a liver becomes cirrhotic, it doesn't work. It stops working. And liver is so important for you, me, and everyone, because that is where everything we eat or we take in is broken down in the liver, almost 80 to 90%. And if the liver doesn't work, how are things going to be broken down? So the other danger is the cirrhotic liver can become cancer. So cirrhosis can actually cause liver failure, and treatment is not possible at that time. You're actually looking at a replacement, a liver transplant. And it's so difficult to find a compatible liver for a transplant. So you find that Hep B can resolve without treatment, but not Hep C. Hep C needs treatment. And we have good treatment, So the combination treatment is pegylated interferon injections and ribavirin. Now there are newer ones. They're actually newer ones, at this moment as we speak. No longer using interferon injections, but newer ones. And people are actually spending a lot of study and research into Hep C. All right. So there are a lot of Hep C medications now in the market. The only thing is, not many governments open it up for free. So many places, you have to sort of wait in line. But it can be treated. It's just like HIV. You can be treated, and your viral load, your hepatitis viral load, can actually come down to zero. The good part is in hepatitis C, it can actually go to zero and stop. So it can totally eliminate in many cases. Now, although it's said to be treatable, it's not as easy as we talk. It all depends on the virus. So the treatment can range from 6 months to a year. And just like anything else, you need very, very close observation and you need to be compliant. There may be some side effects also. So HCV, very common, especially among people who inject drugs. All right. And that's a big problem that we are finding worldwide. So much so that in many countries, when you check among the people or the substance use population, you'll find that the prevalence of Hep C is higher than HIV nowadays because HIV has been controlled. So it's all because of risky behaviors in terms of injecting, sex, and Hep C is actually 5 times more widespread than HIV, more infectious, and easier to be infected. All right. So when we're talking about SUDs, there is a high risk practice, unprotected sex, especially among the sex working population, commercial sex workers, and also because of other diseases that you have, like TB and other things, you find that they are more immunocompromised. But behavior is the huge thing, dangerous behavior. So whereas what we see now is on research, we see that the rates of HCV or hepatitis C is basically higher than HIV, like I said, because we've got heart, and we've got proper protection. So as SUD counselors, okay, you got to watch out for all 3 of this. So your main role here is 1, educate your clients about HIV, tuberculosis, hepatitis. Of course, if it's a male and female client who are basically in the sex working industry, then you're also talking about STDs. Don't forget STDs. education goes a long way. You can't stop people from sexual practice, but what you can do is you can teach them about safe sex practices, contraceptions, the use of condoms. In females, you have intrauterine devices, copper T, the use of spermicidal products, and many NGOs and places around distribute condoms and lubricants, so important, especially when you're talking to your clients who come from the MSM population, the homosexual population, the transgender population, because anal sex is high risk for these infections. And of course, when needed, referrals for testing. Everyone should know their status. So important. All right, so I'm coming to an end here. Okay, so I'm going to stop here and maybe for the next remaining couple of minutes, open up for any questions on the last module or anything that we have covered from yesterday evening till today. Any questions at all?
Hello, sir.
Yes, hi.
Hello. Can HIV be transmitted due to traumatism?
Sorry, can Dr. Min, can HIV
be transmitted between lesbianism or tribalism?
I didn't catch your question. Can it be transmitted between?
Lesbianism, between two women.
Lesbians. Okay. Homosexuality. Well, it depends. It depends. I'm thinking about how. Okay. So if it's homosexual sex, so then there's a lot of oral sex. Okay. There's a lot of oral sex. Now, the rate of infection through oral sex is lower than vaginal or anal sex, definitely lower. But it all depends if there is injury, if there's lots of bleeding, and if that means you must need injury from both sides. That means a tear in the mucous membrane on both sides. So the rates are very low. I cannot say zero, but it's very low. But HIV is very low. But of course, you can get other infections. STD is extremely high.
Thanks, sir.
Any other questions? Part of my work is also with an NGO. And what we do in that NGO is we reach out to transgender population. We reach out to the MSM or the homosexual population. And we also reach out to the commercial sex workers. So we do a lot of work. The NGO that I'm also connected to does a lot of work in harm reduction. So we work into the field of HIV, hepatitis, and STDs. Something that you all do a lot in Thailand, I know. I'm not too sure about Myanmar. Any questions from anyone?
Professor, I have a question. Actually,
Yeah, sure.
I'm quite interested in the analgesic or opioid abuse in the people who are suffering or have been suffered from the musculoskeletal disorders. So these are the treatment of these disorders. So have you ever experienced these kinds of clients?
You're talking about prescription opioids?
Sure.
Yeah. That is the trend that we are seeing nowadays. When you see worldwide research, you see that injection opioids dependence is coming down. Prescription opioids, like oral prescription morphine and other tablet form opioids, are actually on the rise. Yes, it is actually quite high. We don't have much statistics in my country, and I don't know whether you have it, but the way they present is almost similar in terms of injectable opioids. So the way we treat is also similar. You can still use opioid replacement therapies that are used for injecting heroin users like methadone and buprenorphine. So those are still possible to be used.
Thank you, Professor.
Any other doubts, questions? Okay. All right. So I think you are, according to my schedule, you're actually going into a 15-minute break. So I think you need that break to clear your mind. I think Dr. Tiru takes over from me next. I hope that that 1 day of module or UTC 3 has actually helped a bit. Okay. So just for a very fast wrap up, I'll just take about 5 minutes. Sorry. Remember what you have learned. Okay, there are a few takeaway points that you must remember. One is remember that the rates of co-occurring mental health and substance use disorders are very high, almost up to 50%. So it is always good to ask for mental health problems and medical co-occurring problems among your SUD patients. And remember that they are always going to be, COD patients are always going to be more difficult to treat, more chronic, more challenging. So be ready for that. Your best way of treatment is basically an integrated treatment at an enhanced center where you can treat both the SUD and the medical or the mental health disorder. Same place, same time. That's the best way of treatment. Remember, always screen for mental health disorders, the more common ones, especially depression, suicide, anxiety. Never forget personality. Personality disorders people forget, but it's very common. And as common as that, ADHD sometimes. Because it's so important, because only when you detect them and you treat them, then your entire treatment becomes holistic. Make a difference between co-occurring and substance-induced disorder. Okay, so important for long-term treatment. And don't forget your medical co-occurring disorders. So a few other take-homes that you see, remember, in a female patient with addiction, never miss out asking for a past history of sexual abuse. In a patient with depression and SUD, never forget or feel scared to ask for suicide. It is so important. All right. So those are some of the takeaway messages that I can give you. I hope it has been helpful for all of you. Okay. And wishing you all the best in your next 1 and 2 days of your training. Okay. So I think I'll hand over to, who do I hand over to? I think, so, is it? Yeah. Okay. Thanks, Dr. Chiku. I think you're next after the break. So maybe I would say thank you a lot. Thanks a lot, everyone. Okay. My apologies for any mistakes or any deficiencies from my side. Okay. Wishing you all the best. Bye-bye.
Thank you, Dr. Siva.
Thank you.
Thank you, Professor.
Bye.
Thank you.
Dr. Tiru, see you. All the best.